Hello, everyone. This is Dr. Hemi Soneja. I'm a senior consultant diabetologist at Max Smart Hospital, Saket. Today, I'm going to talk about how diabetes management has changed over a period of time, especially over the past few decades. We have moved from a glucocentric approach to now it being a cardiometabolic renal approach, with us targeting more than just glucose control, but looking more at benefits with regards to cardiovascular and renal parameters as well. With more medications in our armamentarium, the onus is on us to make the most of them and individualize therapy for our patients. Today, here, I am discussing a real life case scenario of a 52-year-old lady who had diabetes for around 20 years. She had a BMI of 28.5, which was not too high, but she had significant truncal obesity. She had been on metformin 500 milligram twice a day, glimepiride 2 milligram twice a day, and mixed insulin 30/70, 18 units in the morning and 14 units before dinner. Her main concern was having significant fluctuation in her sugars, and every time someone would increase her dose, she would start having issues with hypos, which would deter her from adjusting her insulin doses furthermore. She had also had a PTCA 6 years ago, and when I saw her HbA1c was around 8.3, LDL of 75, UACR of 300. So for this patient, the main challenges which we had were the uncontrolled hyperglycemia, the obesity that she was struggling with, the microalbuminuria, and of course, the history of coronary artery disease. So with all of these things in mind, we see that she is at a high risk of ASCVD. Now, type 2 diabetes, we know it is a complex disease characterized by chronic hypoglycemia, which typically tends to progress over a period of time. It's also associated with other cardiovascular risk factors like abdominal obesity, hypertension, dyslipidemia, the thrombogenic status, which goes along with that, low-grade inflammation, and the oxidative stress. And these risk factors accelerate the problems like MI, stroke, and peripheral arterial disease. Almost 2/3 of patients with type 2 diabetes die from CVD and almost half of them from CAD. Now, over the last 2 decades, we have been able to better manage our patients and thereby working on reducing the incidence of CV complications. But still, there tends to be that residual risk, which is high. CKD, again, remains a concern, and heart failure as well is a complication of major interest. And now, lately, ADA and several other eminent bodies have recommended that CV protective agent should definitely be considered as a first add-on in OHAs in case of established cardiovascular disease in patients with type 2 diabetes. We have had the DPP-4 inhibitors for a while, and then we've had this latest add-on with the SGLT2 inhibitors, which have been a boon. They are very efficacious glucose-lowering agents. And when we combine these with DPP-4 inhibitors, we get this really efficacious molecule, which is, I would call it as a super pill. Which is highly efficacious and has all the other benefits that we are looking for. With empagliflozin, we've seen the EMPA-REG outcomes, and we are very familiar with that. It showed a significant benefits of empagliflozin and the risk of heart failure by around 35%. In patients with a baseline history of heart failure, empagliflozin was associated with a numerically lower rate of HHF and CV death. Furthermore, it is being postulated that SGLT2 inhibitors might actually prevent the development of heart failure also in diabetic patients. We've had a good positive top-line results from EMPEROR Reduced, which were recently published, and it showed that it was efficacious in patients with HFrEF with or without diabetes. Further, in a sub-analysis from EMPA-REG study also, empagliflozin decreased the new onset or worsening of nephropathy as well by 39% on top of RAS blocker therapy. Now, with this unique mechanism of action, SGLT2 inhibitors, they offer a lot of pleiotropic benefits, including improvement in the blood glucose levels, the natriuresis, decrease in the blood pressure, the body weight changes, liver fat percentage changes also, which have been noted with the use of SGLT2s. And it might actually confer protective effects on the kidney by reducing CV and renal risk factors. Alongside, when we look at linagliptin, it has a unique profile, as we all know. It has primarily non-renal but hepatobiliary route of elimination. And it does not require any dose adjustment in patients with CKD or liver disease for that matter. Carmelina study, which was linagliptin CV outcome study, confirmed that linagliptin reduced the progression of albuminuria by 14% and also decreased the risk for progression of the condition. So, these two medication combination with linagliptin and empagliflozin, it is a very effective strategy to target the HbA1c without having issues with hypoglycemia and weight gain. Now, going back to this patient that I was talking about, so in addition to the metformin and glimepiride that the patient had already been on, I added this combination on top, decreased her insulin doses, in fact, along with that. And now, 3 months later, she's at metformin twice a day, glimepiride 1 milligram twice a day, empalina combination, and along with that, just a once a day degludec and aspart combination. And not having issues with hypoglycemias, her latest HbA1c came back at 7.1, which she hadn't seen in a while. So, with the better management of blood sugar levels, better diabetes control, it helps relieve a lot of other stress factors for the patients also. Diabetes can be a condition where we see a lot of issues with depression as well, which is often ignored. And, that chronic hyperglycemia itself can cause issues with these problems. So with all of these things in mind, I think it is very important that we make use of the agents that we have available at this point of time and give our patients the benefits that they deserve and they need. Thank you so much.